Welcome back, everybody. We're so glad that you stuck it out with us till the end. I hope everyone enjoyed the break as we're filing in. We are excited to see everyone here and see the remaining presenters this afternoon. I am Jamie Robinson. I'm one of your moderators today. I'm an assistant professor of pediatric surgery and biomedical informatics at Vanderbilt. My co-moderator needs no introduction, Dr. Stephen Lee, and he's professor and chief of pediatric surgery at Seattle Children's. A gentle reminder to those of you who are completing the scoring evaluations to complete them no later than 5:30 this evening so that they can be counted in our evaluations. This session focuses on general pediatric surgery, and it is my honor to introduce our first presenter today. I will note that the order is changed slightly. Our third presenter will actually go forth to accommodate keeping someone on stage. So for our first presenter, we have Dr. Anna Lynn. She is coming to us from Nemours Children's Health in Delaware, and she will be presenting disparities in engagement with an artificial intelligence-based intervention post-appendectomy.
Thank you for the opportunity to speak today. I have no disclosures. So since COVID-19, technology in healthcare has increased in utilization, including patient portal use and post-operative visits. Text messaging chats have helped connect patients with medical providers. And mobile applications have been developed for post-operative patients to provide educational material, monitor pain, send reminders to schedule follow-up visits. Our prior study demonstrated a text messaging system in conjunction with telehealth services reduced ED visits after appendectomy. So the objective of this study was to explore differences in chat engagement according to social determinants of health, SDOH, risk factors in an AI-based texting platform post-appendectomy. For the setting, Nemours consists of 2 freestanding children's hospitals in separate geographical regions in the eastern United States. We have healthcare system appendicitis pathway to support standardization of post-operative care for children with complicated and uncomplicated appendicitis. The participants included all patients who underwent a lap-appy at our 2 hospitals from March 2022 to December 2023. We had a total of 1,084 patients in the cohort. Chats were offered via email or text at multiple intervals up to 30 days following appendectomy, and all patient families had to opt in to take the chats. For the analysis, we did a chi-square test to determine whether patient demographics were associated with engagement. So I want to take a moment to show screenshots of the chat system. Following appendectomy, patients were sent a text message invite to enroll. They were offered in English and Spanish. The initial chat contained terms and conditions of the chat and request to opt in. Following acceptance, subsequent chats included housekeeping, such as how was the patient doing, as you can see here. And then depending on the patient's responses, there were chats about incision care, diet, symptom review, resuming activity, and a way to connect with our on-demand telemedicine physicians or the surgeon's office. So here are chat engagement definitions in our study. Engaged was considered 2 or more chats, including clinical content. Somewhat engaged was 1 chat, which included terms and conditions, and non-engaged was no chats at all. First, let's look at chat adoption by race. You can see that white patients were more engaged in chats compared to non-white patients. Next, non-Hispanic patients were more engaged with chats than Hispanic patients. Here you can see English-speaking patients were engaged more in the chat than non-English-speaking patients. And even with insurance type, patients with non-Medicaid insurance were more engaged in the chats than those with Medicaid insurance. Looking at medical complexity, medically complex patients are defined by the Children's Hospital Association classification system of clinical risk group 5B degree or higher, such as patients with short gut syndrome. Interestingly, more non-medically complex patients were more likely to be engaged compared to medically complex patients, though we will note the number of medically complex patients was low at 33 patients in the cohort. And then lastly, we looked at patient engagement by social deprivation index. SDI is a measure of area-level deprivation based on 7 demographic characteristics collected in the American Community Survey. The first quartile is the least deprived, while the fourth quartile is the most. Here on the graph, you can see that engagement decreased with increasing SDI quartiles. So SDOH-related risk factors were significantly associated with engagement in an interactive AI platform after appendectomy. More vulnerable patients, those at highest risk for complications, were less likely to engage. To conclude, digital healthcare tools are important to reach families. We, as providers, must ensure there is digital health equity for all populations. And further research is needed to identify ways to digitally engage the most vulnerable populations. Thank you.
Very well presented, and a topic that's very near and dear to my heart for sure. One question I had is, with the importance of implementing these AI technologies and ethical circumstances that are mindful of the disparities within the populations that we treat, I am curious how many patients were not candidates for the follow-up because of the limitations of English and Spanish only within the platform, and then also as far as the engagement with the chat, did you see any impact of those who were engaging with the chat? Were there fewer phone call or in-person follow-up visits associated with it?
Yeah, so our chat system was offered in English and Spanish. The Spanish language, though, was offered at a later date, and it's something we're actually going to look back at and see if there was any difference within the Spanish-speaking population specifically. In terms of like actual reduction of calls and such, so prior to the study, the first study I mentioned we did, it was more of a homegrown text messaging service, and so that study decreased our ED return rate from like 5% to 2.4%. So we were already pretty low to begin with. And then they introduced this AI text messaging platform, and we were able to sustain that rate of ED returns. So it kind of, we kind of were already ahead of the game when we implemented this text messaging service, but it helped sustain that rate.
Logistically, what do you do when they don't respond? Do you have a backup method of contacting patients?
Yeah, so if they don't choose to opt in, then they won't get the messages. Interestingly enough, that previous study I mentioned, that was actually an opt-out our text messaging service. And so we kind of were thinking about this recently, how this text messaging, or the AI text messaging service was an opt-in versus an opt-out option. So we're going to look to see if, having patients have to opt out will make a difference in terms of engaging with digital technology.
Great. Thank you.
Thank you.
Our next presentation is by Dr. Julia Ferreira. She's a research fellow at Montreal Children's Hospital, McGill University Health Center. The first of her 2 talks will be hashtag CB Clips, the international impact of a social media-based pediatric surgery interactive educational program.
Thank you, everyone. It is an honor to be standing here today. So I have no conflicts. We all know that traditional learning methods cannot keep up with the massive amount of new scientific knowledge. A shift in surgical education is already happening, and nowadays, knowledge delivery must align with surgeons' busy schedules, following a more small, bite-sized approach. Social media platforms are democratizing education, making knowledge available to everyone in every country without costs. Although imperfect, social media can be a bridge between the past and the future of surgical education. But despite social media's influence on learning and networking, its role and impact on surgical education remains undefined. So CB Clips is an online educational series accessible via X, Facebook, and LinkedIn that was launched in 2020 and has 50 episodes so far. And soon they will also be available at the Hendren Project website. CiviClips aims to allow everyone to learn or consolidate an important principle in just a few minutes. It has 2 posts. The first post presents an episode, and the second post is the video commentary about that episode. It provides evidence-based principles, and it takes audience participation into account. So this is an example of a first post that has the case and ends with a query about what should be the next steps. Then it comes a period of dynamic and interactions and co-learning, where people will comment and even post similar cases and everything they're also interested in. Gonna pass.
Hello everyone, and welcome to another are in the same loop or are in different loops. And that's a very important principle in managing this child. The second is that you have to have a very low threshold for suspecting bowel injury. More likely than not, in many of these ingestions, bowel injury will occur. And the third is that the trajectory of the findings, the trajectory of the x-rays in an asymptomatic patient will tell you if these magnets are together or separate and will dictate the management.
So this is the amazing Dr. Emil presenting the cases and making pediatric surgery easy for everyone. So we developed a mixed method study to evaluate the impact of CiviClips by analyzing social media engagement metrics and assessing audience feedback on the program. CiviClips was highly relevant to its viewers on all 3 social media platforms. X had the highest impressions and engagement rates, Facebook had the highest rates of likes and comments, and LinkedIn, although lower than the other 2, still had higher and consistent engagement metrics for these types of programs. To illustrate, for example, for X, a good engagement rate is around 0.5% or 1%, and CiviClips had a median engagement rate of almost 7%, which indicates a very, very active audience. We had 290 people responding to the survey, and we were able to analyze 160 surveys. They were from 71 countries on 5 continents. Most of the people were pediatric surgery subspecialty. 65% were actually practicing physicians, and 25% were trainees, and the rest were nurses and other professions. Overall, 86% of the respondents was very satisfied with CiviClips as an educational resource. 83% rated CiviClips overall quality as good or excellent, and 81% defined CiviClips episodes as engaging. 76% of our respondents improved their knowledge due to CiviClips. 68% applied knowledge from CiviClips in practice, and 93% recommended CiviClips to others. As for our main limitations, one is the social media metrics accuracy is not 100%. We had self-selection bias on the survey. Obviously, people that liked CiviClips would respond to the survey. And we had also a high rate of incomplete responses. But to conclude, CiviClips' reach and success demonstrates the effectiveness of social media-based platforms to enhance pediatric surgical education. I would like to thank the Saputo Foundation for their support on my research, and especially Dr. Emil and you all for listening. Thank you very much.
Any questions from the audience?
Hi, I'm Paul Erner from Edmonton. This is a really cool project. Thanks for sharing your work with us. In terms of reproducibility, about how many hours of work is it for you and Dr. Emil to actually create one of these episodes? And then how much work is it for you to monitor all of these responses?
That's an excellent question. Thank you. And I can say that the amount of work is mostly Dr. Emil doing and producing all of that. My work was basically analyzing the data, and the platforms do help because they will give you engagement rates and everything, so it's not that difficult. But the produce part, I will...
3 hours per episode, essentially.
Yeah, for Dr. Emil.
Right.
You know.
Right.
So about 10 hours for everybody else. So this is phenomenal work. Great job. My question is, it's largely an international platform. How do you take into account the different resources that the other countries have when treating patients? And are the pediatric surgeons and specialists able to post their own cases to kind of cast a wider net? Because sometimes we have a lot of cases that we do here in North America, and it's not applicable to the rest of the world. Just curious of that.
That's an excellent question, especially that I come from Brazil, so I do know what you mean. But I guess what makes Civiclip special is the time period of interactions. So in the end, a lot of people are talking to each other and even presenting, well, but I don't have that resource. What should I do? What can I do? And in the end, Dr. Mill will comment on those comments as well. So the interaction part and co-learning, it's all wrapped up on the final video that he will address anything that it's there.
Maybe I'll just add one quick comment, Steve. So that's a great comment, because if it's international, it should come from an international audience. So that's actually what we've done. A lot of these episodes are presented by guest presenters. So we've had presenters from Indonesia, from Brazil, from Lebanon, from Japan, with their environment and their pathology that they see. And that's what I hope we continue forward, having more of these guest presenters as well.
That's great. I mean, we would learn just as much from other countries as they learn from us from that standpoint. That's fantastic. Any other questions? Well, Dr. Ferreira is going to remain on stage because they have other engagements to present at. So again, she's a research fellow from Montreal Children's and McGill University. And the second talk is going to be the impact of pediatric surgery fundamentals boot camp on new surgical trainees' perceived knowledge and confidence levels.
Thank you so much again. And I, again, don't have any conflicts. So transition periods within surgical training are characterized by high stress levels and a sense of underpreparedness. These periods have been associated with trainees' burnout and have implication on patient care. Interestingly, patient mortality may rise on these periods. It's known as the July or August effect. Thus, continuous effort are needed in surgical education to better prepare trainees. Surgical boot camps can be a solution to reduce trainees' stress levels and increase their knowledge. Students and residents have variable pediatric surgery exposure, with most of them having limited exposure. There is a lack of studies assessing the level of knowledge, preparedness, and confidence of incoming surgical residents with respect of functioning on a new pediatric surgical service. So the Pediatric Surgery Bootcamp is an annual full-day pediatric surgery bootcamp for incoming residents. It's part of a month-long pre-resident surgery bootcamp. It focuses exclusive on pediatric surgical and anesthetic preoperative care, and it's a case-based with interactive lectures with the objective to provide first-year surgical residents the knowledge and the skills necessary for their pediatric surgical rotations. We developed a cross-sectional study with residents who attended the bootcamp from 2021 to 2023 and completed the anonymous post-course survey. We assessed their knowledge, preparedness, and the impact of the bootcamp on both. From the 114 trainees who attended the pediatric surgery bootcamp over 3 years, 79 completed the post-course questionnaire, which represents almost 70% response rates. Respondents represented all surgical specialties except maxillofacial surgery, and most of them came from general surgery. Interestingly, over 60% of the participants stated that their pediatric surgery rotations would occur during their first year of residency, and 20% on their second year, and only 16% in more senior years. Almost 40% of the residents characterized their baseline knowledge on perioperative management of pediatric patients as weak or very weak, and 58% as average. Only 2 residents said that their knowledge base was strong, and none of them said that they were very strong knowledge base in pediatric surgery. Overall, 89% of the respondents rated the bootcamp topics as highly relevant for their clinical needs. The bootcamp increased confidence for starting the pediatric rotations on 72% of the respondents. It improved the understanding of pediatric surgical management in 88% of the participants. And lastly, 87% of respondents concurred that the course justified the time invested. As for our limitations on this study, this was a single-center institution study, so generalizability is limited. It has a correlation with self-assessment and performance in clinical performance is difficult to make, and the durability of the bootcamp effect over time remains uncertain. So our conclusions were that the pediatric surgery bootcamp was well received and improved trainees' self-report knowledge and readiness for pediatric surgery rotations. Other programs may benefit from similar interventions on their curriculum. And future studies should focus on knowledge retention and clinical performance after such initiatives. Again, I would like to acknowledge the Saputo Foundation for their support, and I would like to thank Dr. Emil and the entire pediatric surgery division at the Montreal Children's for supporting me in the last 4 years when I was their research fellow. Thank you so much. I'm happy to take questions.
Any questions? While people are thinking, just incredible work again from your lab and that you've performed. I'm curious from the boot camp, what do you think are the aspects of the boot camp, the tangible, if we were to try to replicate a similar type of model, what were the main aspects and formats of the boot camp that you felt like were the most impactful for the residents?
Thank you for the question. I think the most important things was that the lectures were very interactive and case-based. So it was more tangible for the trainees, what they would face, and also involved specific topics and fundamental knowledge on airway, pediatrics, so specific things of surgical patients that is not on their normal curriculum and that they could see on that bootcamp.
Practicality sounds like it's important. That's awesome.
Are these, is the boot camp recorded?
Not really. It's not recorded. It's for in-person attendance. And as I said, it's a part of a month that the trainees goes to different boot camps. We are on doing a follow-up study from that one to assess their long-term knowledge retention. But they are not recorded, no.
Thinking to combine your last two and record them, and then, because you do the boot camp, I'm assuming, early on, and then they may rotate 6 months later. They may be able to access them as a reminder. And then you could share them with all of us, because I would love that. So.
That's a great idea, actually. You're totally right.
Does anyone else use a boot camp? Show of hands. Yeah, you have a wide audience to share with. So, great. Any other questions? Thank you.
Thank you.
For our next presentation, we have Dr. Stephanie Antorno from the University of Utah Health, who will be presenting the impact of interhospital transfer on children with acute appendicitis in California, Florida, and New York.
Hello, thank you for the opportunity to present today. In previous studies using nationally representative data, my research team found that there are clear, disparate interhospital transfer patterns affecting pediatric patients with acute appendicitis based on race, ethnicity, insurance, and socioeconomic status. However, the clinical impact of these unequal transfer patterns was unclear, namely due to some limitations within the administrative database and being able to follow patients from one institution to another. It's my belief that non-standard transfer patterns may drive or contribute to disparities in clinical outcomes, and that optimizing transfers may be an opportunity to reduce or optimize resource utilization and promote equity. Approximately 10 million children in the United States live more than 60 miles from a pediatric surgeon. And as everyone in this room knows, many general surgeons regularly operate on children. Regionalization is increasing for common conditions, but regionalization does not equal optimization. The goals of an effective interhospital transfer system are twofold. Number one, to transfer kids who will benefit from a higher level of care, but also, importantly, to avoid transferring those who can receive high-quality care closer to home. So the question, does interhospital transfer affect outcomes for pediatric acute appendicitis? To tackle this question, we use data from the Healthcare Cost and Utilization Project from 3 states, California, Florida, and New York. We studied all children with a primary diagnosis of acute appendicitis and only included hospitals with documented pediatric appendectomy happening within this year. Our main outcomes that we were interested in were length of stay beyond 2 days, 30-day ED visits, 30-day readmission, and total hospital charges. And we compared patients who underwent transfer to those who received definitive care at their index hospital. We chose these 3 states because they provided visit links to allow us to, again, follow the patient from the index facility to the accepting institution and then look at their clinical outcomes. This is an overview of the total cohort. There were approximately 14,000 children included. A quarter of them had perforated appendicitis, and a little over half were from the state of California. Approximately 5% of these patients underwent interhospital transfer. This slide is busy, but the take-home point is that for both patients with perforated and non-perforated appendicitis, those who underwent transfer were more likely to be young, aged 5 or less, but they were also more likely to be non-white, to have public insurance, and to reside in a lower income quartile neighborhood. This replicated the patterns we saw in our national level data. So for the clinical outcomes, this is for the non-perforated appendicitis cohort. We explored these cohorts separately. We found that patients who underwent transfer were more likely to have a prolonged length of stay, more likely to have an ED visit within 30 days, more likely to have a readmission, and to have higher overall total charges. The same patterns were seen in our perforated cohort, where those who underwent transfer were more likely to have worse outcomes. In conclusion, we found that interhospital transfer is associated with worse clinical outcomes, and that transfer disparities were actually more pronounced in the non-perforated appendicitis cohort. Similar to the national trends, we found in these states that minoritized children were more likely to undergo transfer, even when controlling for all clinical variables. And based on these outcomes, we believe that more standardized transfer processes may be an opportunity for us to better optimize healthcare and to promote equity in children. There are some important study limitations, namely based on the administrative nature of these data. We don't know why the children were transferred, and we may be missing some transfer links that can create biases. My next step for exploring these data further are to link the actual hospital codes, and so I can determine exactly where they presented to where they were transferred and what the capabilities are in terms of surgical anesthesia and IR capabilities. My overall hope is that these results will inspire local systems to perform their own analyses and QI projects related to optimizing transfer patterns. Thank you for your time, and I welcome any questions.
Gilchrist, Brooklyn. I want to make a couple comments about this. The most important thing for all of us, if you want to talk about quality of care, is to get pediatric surgeons into those areas where they're needed. In the city of Boston, where I was for 10 years at the floating, we had 31 fine pediatric surgeons. In the borough of Brooklyn, with 3.5 million people, we've got 3 or 4 pediatric surgeons. We need more people in the trenches taking care of the disenfranchised instead of talking about it all the time and saying how we need to study them and move them. We need to be there in boots on the ground.
Appreciate your comment. Thank you.
Hi, Jennifer Shue from Wisconsin. So you presented a lot of correlation with disadvantaged status, ADI, socioeconomic status, minority status, that we know are linked to worse outcomes. Did you look at whether transfer is associated with worse clinical outcomes independent of those risk factors?
We did. Now, that's a really important question. In our model, we did try to control for, without over-controlling each of those individual factors. We included age, perforation status, and then social deprivation index as well, and found that the relationship persisted. But I don't think that they're unrelated. And hopefully by being able to look more closely at, exactly what hospitals they're going to and where, we can better understand, is this patient sicker than they might be represented by these ICD codes? Is there something else that we're missing here?
And thank you for the work that you're doing.
Thank you. Thank you.
Great, thank you. Great, our next talk is going to be presented by Dr. Megan Rosenberg. Megan is a general surgery resident at Bay State Medical Center, and the title of the talk is Pediatric Rare Earth Magnet Ingestion, Defining Progression in Serial Abdominal Imaging. Dr. Rosenberg.
All right, good afternoon. Thank you for this opportunity to present. We've got no disclosures. Foreign body ingestion is common in pediatric patients. Often the object is inert and will pass without complications. Rare earth metal magnets, or REMs, however, pose a unique risk with a bonding strength 5 to 20 times stronger than that of a conventional iron magnet, which can magnetize across loops of bowel. A sales restriction was lifted on REMs in 2016 in the United States, with a subsequent resurgence in these types of ingestion cases. There are several proposed management protocols for REM ingestion. In the asymptomatic patient who has ingested 2 or more of these, most of those protocols propose inpatient monitoring with serial tracking on subsequent x-rays, but progression is not very well defined. We sought to investigate whether using midline crossing of REMs on plain films would serve as a predictor for successful non-surgical management and thus a good surrogate for a definitive sign of progression. Our study is a single-center retrospective review, which included 31 patients under 18 years old who presented to our hospital system with a confirmed ingestion of 2 or more REMs between 2013 and mid-2024. Data was collected on their presentation, timing of the REM ingestion, radiographic findings, and the ultimate management. On radiograph, we defined midline crossing as a clear passage from across the center of the vertebral column on sequential abdominal plane films. Just some basic statistics about our cohort. The average age at the time of presentation was about 8.5 years old. There was a 1.6 to 1 male predominance. Because we only have a small amount of study data prior to that 2016 change in legislation, it was a little challenging to compare the number of cases before and after the sales restriction. But doing logistical regression by year of presentation, we see an increase of about 0.6 cases per year with a correlation coefficient of 0.8 and R-squared value of 0.7. The average time from ingestion to presentation was about average 10 hours, but it ranged from 30 minutes to 79 hours. On average, our patients would ingest 6 REMs, but it ranged from 2 up to 68. 65% of patients were asymptomatic when they presented. 19 did endorse abdominal pain, 13 had vomiting, and 3 had a sore throat. The presenting symptom did not correlate statistically with the need for future intervention. We also looked at physical exam findings, and again, those did not significantly predict the need for future intervention, although it should be noted that we had 1 patient with distension and 1 patient with peritonitis, and both of those did require surgery. The average length of stay for our patients was 3.1 days, and perhaps predictably, those who required surgery did have a significantly longer stay with us. We also evaluated bowel regimen as a possible confounding variable, but overall, looking at it from a couple different ways, we did not find that bowel regimen from above or below correlated with any decreased need for either endoscopic or surgical intervention. No, we're not advancing anymore. So all 31 of our patients had at least 1 abdominal radiograph, 28 of whom had serial abdominal imaging. For the 3 without serial imaging, the index radiograph showed free air in our patient who came with peritonitis. The one who came in with distension was found to have an obstruction and went to the OR within 3 hours and didn't get a second film. And the third that didn't have serial imaging had a successful upper endoscopy, which removed all of the magnets. For the remaining, 68 had at least one midline crossing of their ingested REMS, while the remaining 32% never crossed midline. Only one patient had a midline crossing that ultimately required surgery, but overall, those with at least one crossing were significantly less likely to require surgery than those who had with no midline crossing, and that was a relative risk of 0.25 and a p-value of 0.01. If we break it down by the number of midline crossings, 0 midline crossings had a relative risk of requiring surgery of 4.56. We do have fairly wide confidence intervals because our sample size that was 0.41 to 49.9, and those with 1 midline crossing had a relative risk of 0.46. 10 patients had 2 or more midline crossings of REM, of whom none required surgical intervention, and because of that, we couldn't calculate relative risk. 84% of those initial midline crossings occurred within 24 hours of presentation. I will note that the time from ingestion to presentation was not controlled for since it wasn't reliably known in all of our patients. Probably about 45% of them knew exactly when they were ingested. As there was only one patient with a midline crossing that underwent surgery, we weren't able to perform any statistical mean analysis between the timing of surgery and midline crossing there. So in conclusion, we know that determining the timing of surgery in these patients who can present with mild to no symptoms and very benign physical exam can be really challenging. We found that with greater than or equal to 1 REM midline crossing, it is a predictor for successful non-surgical management, and that the majority of these crossings will happen within 24 hours of admission. We suspect that there are other REM movement patterns that may be predictive, such as a configuration change, but our study was underpowered to be able to investigate that further. We're in the process of putting together an IRB to hopefully have a multi-center study of this to investigate further and set up a protocol for managing these patients with this information. And I'm happy to take any questions.
Thanks, Sharif Emile, Montreal. We're still learning how to best diagnose and take care of these patients. This would make a great follow-up CV clips, by the way, so just put that on your agenda.
That's the plan.
I'm just curious about 2 things. First, why is midline crossing a criterion? Because it either moves or doesn't. I mean, the ones that have already linked, they don't move. You could do it 12 hours apart or 18 or 24 hours apart. You could impose the x-rays. They do not change at all. So I think any movement is promising. The ones that have already attracted each other, they just don't move because they're stationary. The 2 loops that cannot move. They're glued to each other, basically. The second question I had was, how many of those operated already had advanced disease, like perforation or fistulization, versus just getting them when they're still together? Because our policy is to go early. If they haven't moved on the next x-ray, you go, even if the patient's completely asymptomatic, and we have never had a negative exploration. There's always a problem.
Yeah, fantastic questions. Thank you. For your first question, we hope that it would provide a level of objectivity. There can be so much variability with how these x-rays are obtained, how the kid is positioned. Sometimes it can look like false progression, and it's really not. There's been times also where we see that they kind of get stuck in the ascending colon where it just can't really seem to cross over, and sometimes we'll see it kind of going up and down there. So our main goal was to, by defining midline as crossing the vertebral column, was just a little bit of objectivity in what is otherwise kind of a subjective point of the protocols that are offered for these patients thus far. As for your second question, we had, I believe, only 1 negative exploration of the 10 that underwent surgery ultimately. We have a lot of variability in our practice currently. We've gone from seeing almost none of these cases about 6 years ago to seeing 6 or 7 of them a year. And so I think there's been a learning curve and a change in behavior as we experience these more frequently and try to get a grip on, what are our indicators to take them. So I think this is going to push us towards operating a lot sooner than we have in the past.
Nigel Hall, Southampton. Thanks for this. It's fantastic. I agree with Sharif. It's new, it's practical, it's really, really helpful. So thanks for bringing it to us. A couple of questions. So we've done a similar piece of work where we actually divided the abdomen into like 9 sections rather than just the midline. It doesn't make any difference. It's still hard to do. But it's just an interesting way to do it. So couple of questions. So have you managed to standardize the interval between the x-rays, number one? Clearly one movement across the midline is reassuring. how many x-rays do you have to do in the cases that don't cross the midline? Because if you go endoscoping all of these, you'll find a whole load of kids who actually don't need an intervention.
Yeah.
They will pass them with time. We've kind of come to the conclusion that everyone needs at least 3 x-rays to be really certain of what's going on. So I was just interested how this protocol is going to work out in your hands.
Yeah, absolutely. This was all retrospective, so unfortunately the interval is very irregular. We have calculated it out for all of them so that we can kind of try to control for it. But prospectively, what we're considering right now as a team is saying that everyone gets an x-ray every 6 hours for the first 24 hours, and we'll use that kind of as our landmark. It still has a lot of analysis to be done on that, but that's right now is our mindset, and that would allow 4 x-rays in that first 24-hour period where we've seen that most of the midline crossings happen. So we're hopeful that that will be helpful for managing these.
Thank you.
Of course.
Last question.
Hi, Yusuf Gohari from University of Missouri. Do you find it odd that the average age for a child swallowing 68 magnets is 8.6 years of age?
Yes. So what we did find is that may be our average, but we have a bit of a bimodal distribution. Many of them are kind of in the younger toddler age. They've gotten a hold of their siblings' toys. And then there was another actual kind of peak in teens. And a couple of them, as I was doing this chart review, were kids who were like, oh, I'm going to give myself a fake tongue piercing with these, and accidentally swallowed them. And a couple of them, there was a psychosocial component to this where it was intentional ingestion.
Also, TikTok challenges.
Yes.
One last quick question.
Paul Lerner from Edmonton. Did you look to see if there was a certain number of magnets swallowed as a threshold after which every kid needed a surgical intervention? Like if you see, 6, is that enough to say we don't have to wait, this is just not going to work?
That's a great question, and I actually did not look at it from that perspective, mostly because it's a small sample size, but something that would be very worthwhile looking into. Thank you. Thank you.
Great
Thank you.
job. Our next presenter is Dr. Erin West, a surgical resident at the Naval Medical Center in San Diego, and she will be presenting Bridging the Gap, Identifying Depression and Suicidality in Pediatric Surgical Patients and the Need for Early Screening. Dr. West.
Good afternoon. Thank you for the privilege of the podium. We have a few unrelated financial disclosures. The escalating rates of depression amongst children and adolescents poses significant public health concern. The National Institute of Health reported that 20% of adolescents aged 12 to 17 experienced at least one major depressive episode in 2021. While previous studies have demonstrated higher rates of depression in pediatric medical inpatients and trauma patients, there remains a knowledge gap regarding depression prevalence and risk factors in the general pediatric surgical population. The purpose of our study was to characterize the mental health of adolescents admitted to our pediatric surgical service. We performed a retrospective cohort study at a single children's hospital from 2016 to 2023. Inclusion criteria were patients that were admitted primarily to the pediatric surgery service who underwent surgery during their admission, adolescents aged 12 to 17, and patients who had a complete patient health questionnaire in their record. All patients were screened with PHQ-2, which evaluates for the frequency of depressed mood in the preceding 2 weeks. Patients that scored over 2 on that assessment moved on to the PHQ-9, which is a more complete assessment tool of depression symptoms and suicidality. If patients endorsed suicidality, then further assessment and risk precautions were taken. 513 patients were included. Almost 50% were male. The median age was 15.2, and the majority of our cohort was Hispanic. 21% of our patients had pre-existing mental health diagnoses, with 8% of those being major depression, and 20% had pre-existing chronic medical diseases, including cancer, genetic syndromes, cerebral palsy, and inflammatory bowel disease. The most common surgical procedure performed was laparoscopic appendectomy, followed by laparoscopic cystectomy, cholecystectomy, and ovarian cystectomy. And the median length of stay was 1 day. 2% of patients screened positive on PHQ-2. But 2/3 of those patients scored over 9 on PHQ-9, which is diagnostic of moderate depression, and the same proportion was positive for suicidal ideation. The overall prevalence of depression in our cohort was 10%. The rate of psychiatric evaluation was about 3%. There were 4 patients with a PHQ 9 score less than 9 who received psychiatric evaluation due to other concerns for depression, such as a request by the patient, the family, or nursing staff. Multivariable logistic regression was performed to assess for the relationship of several risk factors with the outcome of positive depression screening. Higher BMI demonstrated a positive association, which did not reach statistical significance. Interestingly, in our cohort, all positive screenings were female, and there was no association between age, pre-existing chronic disease, or surgery type. There were several social or medical risk factors which were significant and are displayed on this forest plot with odds ratios. These included a prior diagnosis of an eating disorder or gender dysphoria, family history of mental illness, or a social history of abuse, familial disruption, or food or housing insecurities. These factors are known to be associated with increased depression in the general population. In comparing the prevalence of depression in our cohort to the literature, the inpatient pediatric surgical population is more similar to other outpatient populations than published depression prevalence in inpatients. Our prevalence was 9.4%, and outpatient prevalences range from 2% in orthopedic offices up to 12.5% in some of the primary care literature. Inpatient prevalences are much higher and can range from 38% in the pulmonology population to up to 63% in some general medical populations. Though our rate of positive depression screening was low, there was high co-occurrence with suicidality. This provided an opportunity for life-saving interventions, including psychiatric evaluation, providing patients with new mental health resources, and getting patients established with new mental health providers. Suicide is the second leading cause of death in adolescents, and in 222, 15.1 adolescents per 100,000 died by suicide. Acute stress is known to be a trigger for suicidal ideation, and for some children, hospitalization and surgery may be that trigger. Our study calls for further research into the relationship between surgery and suicidality and depression in surgery, and perhaps focusing on patients with longer hospitalizations or more major surgery. So in conclusion, depression screening of pediatric surgical patients is a low-stakes and low-cost intervention which can be life-saving. And depression prevalence in inpatient surgical patients is lower than other inpatient populations, but the risk factors do reflect those of the general population. Thank you for your attention, and I'm happy to take any questions.
I think this is very fantastic and very important. We utilized in Central California the Columbia scale before for screening before outpatient surgery, and one of the things that we discovered was that we didn't have adequate resources. We'd screen, and then we didn't have a social worker to come over and assess the patient.
Yeah.
And we actually have, unfortunately, such a shortage of psychiatrists available that we put kids on repeated 5150, which is the legal hold, and we just renew it every 3 days, which is technically illegal. But we do that rather than allow someone to go and commit suicide. So I was wondering, what was your experience during this time period with being able to provide resources for screen positive? You said you provided some resources. What were they? Did you discover there was a shortage? Were you able to take this data to the administration and advocate for additional resources for this purpose? And I do think it's a fantastic study. Thank you.
Yeah, thank you so much for your question. It's a really important issue and a huge issue throughout all of healthcare, not just for children. For our center, most of this counseling was done by our social work and case management. And so they had a lot of kind of resources and pamphlets and clinics that they could provide. I'm not really able to speak to the availability of psychiatrists and that kind of thing, because I know that's definitely a barrier. But in our records, everyone who was referred was seen, and I think that might reflect the fact that we didn't have a super high total number of that. But I think one of the things that was important to note is we had 2,500 eligible patients and only 500 complete PHQs. So this was kind of part of a quality initiative of trying to make sure that we are completing that documentation on everyone.
Hi, Dr. Arya from the Children's Hospital in Alberta. I was just curious of the PHQ-9's validity for the pediatric population, and if that could impact the findings that you had.
That's a good question. I am not totally sure if there's been specific studies validating PHQ in adolescents. I would have to look into that. I know there's been lots of validations in kind of general adults, but yeah, thank you for your question.
And what was the average age of your cohort again?
15.
Okay.
Yeah. We were just doing adolescents, 12 to 17.
When is the optimal timing to administer the questionnaire? Because a lot of these patients are going urgent operations and so forth. In the outpatient setting, we do it in the intake, at their intake. So what would you suggest for these patients?
Yeah, in our hospital, they were getting this as part of like their screening questions when they were first getting admitted kind of into the room. But we do want to implement it more on kind of the outpatient side because I think it would be valuable to have, especially at like post-op visits in the clinic.
Yeah, I can imagine someone with acute appendicitis and active pain might answer differently.
Yeah.
Or it might have impacted the number of questionnaires that were actually
right. Yeah,
completed,
definitely. Like,
as you
you know,
mentioned.
some of the ones who went straight to surgery and then to the floor after probably were some of those missing evaluations.
Yeah. Great work.
Thanks.
Our next presentation is by Dr. Zoe Flyer. Dr. Flyer is a fetal surgery research fellow at Children's Hospital of Orange County. And I think it's a video here.
Trauma remains the leading cause of death and disability among children in the U.S. Trauma outcomes can depend on where patients receive care. This can be particularly true of pediatric patients, where pediatric centers are specially equipped to treat the medical needs of children. Minorities face disparities in trauma care. They're often treated at different hospitals than their white counterparts, and this may affect trauma outcomes. Some of the existing literature has reported on higher than expected mortality rates across all ages at hospitals where Black trauma patients are treated. A higher incidence of in-hospital mortality was also seen in uninsured Black and Hispanic pediatric trauma patients. Where trauma patients receive their care is largely dependent on trauma catchment areas and the EMS transport within them. There have been reports of race-related EMS transport discordances that are specific to adults and also to children when it comes to transporting to adult versus pediatric trauma centers that are best equipped to cater to the needs of children. Ultimately, the role of EMS transport in pediatric trauma patients, but with particular attention to their racial and ethnic backgrounds, remains understudied. The Dissimilarity Index is a unique tool, a way of measuring the evenness of distribution of two groups across a single geographic area. A DI, or Dissimilarity Index, of 0 is a perfectly mixed population, and a DI of 100 is a completely separated population. For example, zip codes A and B are made up of populations Y and Z. As you can see, there is far more of population Y than Z in zip code A. And there is far more of population Z than Y in zip code B. Using these proportions, the calculated dissimilarity index would be 0.6 or 60%. A dissimilarity index of 60% means that 60% of either populations, Y or Z, would have to move to the opposite zip code in order to even out their distributions. Using dissimilarity index specific to zip code, an important 2023 study revealed that discordances do exist in the EMS transport of white and non-white adult trauma patients. This study seeks to build on these published findings by examining EMS transport of pediatric trauma patients for similar racial and ethnic disparities. So, we hypothesize that racial and ethnic dissimilarity exists in the EMS transport of pediatric trauma patients who become injured within the same zip code. We used de-identified EMS electronic records from the ESO database during the years 2021 and 2022 for patients less than 18 years of age. We made comparisons of EMS transport destinations within zip codes using dissimilarity index for white versus non-white pediatric patients. 662 zip codes met inclusion criteria. There were a median of 92 transports and 10 destination hospitals per zip code. The median dissimilarity index per zip code was 3%. Nearly a quarter of the total patients came from zip codes with a dissimilarity index greater than 5, and 6% of patients came from zip codes with a dissimilarity index greater than 10. Median dissimilarity index was increased in children ages 6 to 12 years old when compared to younger patients. Median dissimilarity index was also increased in those of Hispanic ethnicity. Increases in median dissimilarity index were seen in more urgent transports, where lights and sirens were used, advanced life support was provided, and by EMT provider role versus paramedics. A sensitivity analysis was run, first specific to even versus odd age patients. Even versus odd age patients were first examined to determine the dissimilarity index for a random discordance, unrelated to more specific patient characteristics. Then, the sensitivity analysis was limited to white, Black, and Hispanic patients, and revealed that the median dissimilarity index for Black versus Hispanic patients was similar to that of white versus Hispanic patients. The median dissimilarity index was lower, however, when comparing white versus Black patients. Overall, the median dissimilarity index appreciated in race-related analysis was far greater than that of even versus odd age patients, indicating that race-related discordances were not random. In conclusion, small but meaningful dissimilarities were noted in the destination hospitals for white and non-white pediatric trauma patients transported by ambulance from trauma scenes within the same zip code. This suggests that EMS transport contributes to discordances in where white and non-white pediatric trauma patients receive trauma care, and serves as a basis for future research regarding strategies to mitigate inherent bias that exists in healthcare. Thank you to the ABSA committee for allowing us to present our research today.
Any questions? No, I'm just kidding.
Wonderful. So for our next presenter, we have Dr. Nicole Santucci. She is a general surgery resident from Washington University in St. Louis, who will be presenting Identifying Disparities in Pediatric Same-Day Surgery Cancellations, Impact of Race and Socioeconomic Factors in a Pediatric Health System.
Thank you to ABSA for the opportunity to present our work. Hospital leadership in surgery and anesthesiology noted a high rate of same-day surgery cancellation across our system. And we know that there's disparities in access to care amongst different disease processes in surgery. Unexpected surgery cancellations impacts patients and families with downstream effects that include patient and family dissatisfaction, increased economic burden, wasted resources, and potential short and long-term impacts on patients' health. Prior studies have looked into both preventable and non-preventable causes of same-day surgery cancellations, but there's been little investigation into same-day surgery cancellations and socioeconomic factors. This is important because we know, as demonstrated by many talks today, that pediatric patients who are socioeconomically disadvantaged have worse outcomes. So we sought to identify how demographic and geographic factors impact same-day surgery cancellations across 3 separate sites within our hospital system. To answer this question, we performed a retrospective case control study. We queried the EMR over a 2-year period and included all surgical cases and procedures for patients who underwent an elective procedure with same-day discharge within our hospital system. The primary outcome of interest was case cancellation status, which was recorded in the EMR at the time of cancellation by either nursing or hospital administration. We were also particularly interested in looking at these groups by operative site, our primary academic hospital, St. Louis Children's Hospital, and our 2 outpatient surgery centers. These 3 sites are all part of WashU and all have the same surgeons operating at all 3 sites, with the outpatient surgery centers solely performing elective ambulatory ASA class 1 and 2 cases. We included cases that were canceled for any reason, including patient logistical reasons, patient medical reasons, system reasons, and perioperative reasons. Secondary outcomes included patient demographics, socioeconomic factors, including childhood opportunity index, reason for cancellation, and the type of surgery canceled. COI is a national measure that includes indicators of social and structural determinants of health across 3 domains, and we matched zip codes at the time of surgery to this measure, which is reported in nationally standardized quintiles from very low to very high. A total of 27,000 same-day surgery cases were scheduled across our 3 operative sites with an overall cancellation rate of 7.3%. We compared canceled and non-canceled groups using t-tests for continuous variables and Pearson chi-squared for categorical variables. The canceled cohort tended to be younger, male, and African American, and the canceled cohort also tended to reside in the lowest COI composite index areas, whereas patients with non-canceled cases tended to reside in the very high and high COI quintiles. In a sub-analysis of canceled cases stratified by hospital location, comparing the primary academic hospital to the outpatient surgery sites, we found that the primary academic hospital had 60% of the total canceled cases, and these patients tended to be older, Black or African American, and have the lowest 2 COI indices. The primary catchment area for St. Louis Children's Hospital includes St. Louis metro area on the eastern border of Missouri, as well as the neighboring counties across the Mississippi River in Illinois. We'll be focusing on this part next. This figure demonstrates the nationally normalized COI quintiles by zip code for our primary catchment areas. The 3 stars represent the 3 operative sites. The purple and blue are the low and very low areas, which are surrounding our urban primary academic hospital. They're very socioeconomically disadvantaged with the low and very low quintiles. The outpatient surgery centers are in high opportunity index suburban areas, which are located here. Again, on the left is COI by zip code, and on the right details the figures for frequency of cancellation for our primary hospital. Cancellations tended to cluster around zip codes near the hospital, and interestingly, we saw a focus of cancellation zip codes that coincided with the area of the lowest COI indices, with some zip codes that were outliers. Our study had several limitations. First, this was retrospective, and so it was difficult to accurately assess the reason for cancellation in some of the surgeries, and we didn't have any insight into how site was determined at the time of scheduling. We also excluded data prior to July of 2022, secondary to COVID. And this data reflects St. Louis, which may not be generalizable to other areas. And while COI is an excellent measure, it does not include all aspects of social and structural determinants of health that may impact patients. In conclusion, patients from racial minorities and low neighborhood opportunity had higher rates of same-day surgery cancellation across our system. In St. Louis, racial segregation is highly associated with socioeconomic segregation. And these vast differences were apparent in our geospatial analysis as well as our data. The lowest quintile of COI overall was primarily composed of Black and African American patients who were scheduled for surgery at the urban primary hospital, which is in closest proximity to zip codes that are historically racially segregated. Our results add to the growing body of evidence that there are important neighborhood and system level changes to make access to surgery more equitable. Our group is going to be collecting qualitative and quantitative data, talking to families directly whose cases have been canceled to better understand system and structural factors that impact same-day surgery cancellation and the economic and emotional toll that this takes on patients and their caregivers. We're collaborating with community partners on this next stage of the project with the hope of establishing an intervention that improves the care for patients in our hospital system. I'd like to acknowledge my team, and I'll take any questions.
This is really important work that you and your team have done. I think these same-day surgery cancellations impact the patients significantly, and they also impact the system. What are your thoughts about your overall kind of how, when you do implement and find more about why these same-day surgery cancellations are occurring, how can you, how would you consider implementing changes in your overall scheduling process and how to limit those same-day surgery cancellations?
Yeah, thank you for your question. I think that's why we want to talk to patients' families directly, because we're not really sure, we have an app, we have nurses that make phone calls, we have a lot of things already in place to help access for patients, but there's still obviously wide disparities. And so we're planning on really partnering with the community and then also talking to people and seeing what are the actual barriers that they're facing and then targeting the intervention based on that.
Yeah, I think about models like an airport where they're overbooking for flights, and then, I'm not sure that's the right model, but how do we make this more efficient for all?
Yeah, thank you for your question.
So I had a question about cancellation.
Yeah.
So if a patient had a cough and a fever and they called 5 days early, would that have, and they rescheduled, would that be caught as a cancellation? Because an alternate interpretation of the data could be that the people from low socioeconomic status don't have access to rescheduling with ease, right? And actually the scheduling is a big challenge, making sure that you have a ride, transportation, managing the buses, getting the prescriptions, and et cetera. And I would worry that perhaps what we have is a disparity in the access to just fixing the date if you're not able to, for example, call from your work because you're the sole income provider for your family.
Yeah, excellent question. So we did include those in our data set. And actually, when we looked at the patients, the low COI patients who were canceled, they were more likely to be canceled for reasons like that of, not having a ride, transportation issues, showing up and not adhering to NPO status. And so I think, it's more important work to tease that out more in the future.
I want to point something out to you. The reason these people, 35% of my kids cancel in Brooklyn, it happens. They can't get there, the train's not working, there's nobody to take care of the other kids. The real issue, the a priori issue, basic principles, Marcus Aurelius, it's because they're poor. And why are they poor and disenfranchised? Because we have systemic racism in this country. And until such time as people get fair wages, a decent minimum wage, they'll still be poor. So we need to fix the fundamental issues in society. So vote early, vote often, vote Democratic.
Yes. Thank you for your comment.
Great work.
Great.
Thank you.
Okay. Our next presentation will be by Dr. Seth Sailors. Dr. Sailors is a surgical scholars research fellow from Children's Mercy. The title of Dr. Sailors' talk is Switching Lanes, Leaving Behind Discharge Antibiotics and Laboratory Testing in Perforated Appendicitis.
Hi there, and thanks for the opportunity to present our work today. Maybe. There we go. We have nothing to disclose. So why am I presenting today? I would imagine everybody in this room is probably taking care of appendicitis at some point in their career. So it's a very common problem that pediatric surgeons deal with. And so we feel any improvements we can make in managing care of complicated appendicitis can have a large-scale impact, even if it is a small change or improvement. And hopefully it's an opportunity to avoid any unnecessary burden and costs on our patients. So just as an introduction, the development of an intra-abdominal abscess after complicated appendicitis is a common complication, and it's been shown to significantly increase length of stay, morbidity, and overall hospital charges for these patients. And one of the treatment factors that still has variability among pediatric surgeons is the choice of antibiotics and the timing of antibiotic duration. So we wanted to see if we could improve this to make any changes. So the purpose of the study, we wanted to see if the post-discharge intra-abdominal abscess rate of patients with perforated appendicitis would be impacted if we changed our protocol, stopped checking white blood cell counts, and stopped discharge antibiotics. So for our methods, we did a prospective observational study from May of 23 to May of 2024 at our institution, looking at all pediatric patients treated with complicated appendicitis, which we defined as a hole in the appendix or a fecalith present in the abdomen. And so we have our old protocol on the left, which is these patients would receive IV antibiotics, which we used dual antibiotics listed below. They would receive that daily, and then on the day of discharge, once they met our criteria, which was just looking at clinical status, which was pain was well controlled and they were tolerating a regular diet, we would check a white blood cell count on that day, and then if it was greater than 10,000, we would prescribe an outpatient PO course of antibiotics for a 7-day course. So when we started this in May of 2023, we continue our IV antibiotics, we stop with the white blood cell count, and we stop prescribing outpatient antibiotics. So what did we find? We treated 202 patients during this period with complicated appendicitis, an average age of 9 years. Most patients presented with nausea and vomiting, and about half of our patients were having fevers, clinically diagnosed fevers at the time of presentation. We had 20 patients out of this cohort that returned with a post-operative intra-abdominal abscess. And this table is just highlighting that there was no significant difference in the age of these patients, their BMI status, or the initial index length of stay, and consequentially the dose of IV antibiotics that they had received compared to the patients that did not develop an abscess. We did see a statistically significant difference in operative time, but that is something that we can't really elaborate on further than that. Looking at the patients that returned with abscesses, so the average post-operative day that the abscess was diagnosed was right under 9 days. 3/4 of patients required readmission and had an average length of stay of 3.6 days. 60% of patients were able to be treated with just an extended course of antibiotics, and 40% required interventional radiology drainage with antibiotics as well. No patients required reoperation. So kind of the crux of this, looking at our old protocol with a prior study of 270 patients, we had an abscess rate of 8.1%, and then in our new study, we had an abscess rate of 9.9%. But on statistical analysis, there was no statistical difference. So some takeaway points. Stopping antibiotics at discharge for perforated appendicitis did not seem to change our abscess rate statistically. And then most patients that developed an abscess were able to be managed without additional procedures. We also do not see utility in checking a white blood cell count at discharge to determine the need for discharge antibiotics. This study has its limitations. It's a single institution study and it was non-randomized. Although I would highlight that our institution is heavily protocol driven. So even though they were not randomized, there was really not difference between each cohort pre and post implementation other than checking the white blood cell count and doing the PO antibiotics. Future directions would be to see if this could be replicated at a multi-institutional study to do true randomization or to look at other clinical factors, whether it's inpatient or intraoperative, that may be predictive of developing abscess. And some of these things we are currently working on as well. Thank you, and I'll take any questions.
Appendicitis always gets people to the mic.
Yes. Dr. O'Reilly again from Alberta Children's Hospital. Just curious if you had a standard antibiotic sort of algorithm that you used, or if all your perforated appendicitis got the same across the board, and then what discharge criteria? I might have missed it in the presentation if you covered it.
Yeah, so yes, we do have it is standardized. I'll go back to, so all patients will get, unless there's an allergy, they'll get IV ceftriaxone and metronidazole, and then when we switched to PO previously, it was Augmentin, again, unless there was allergies. And then our criteria when someone was ready for discharge is that their pain is under control and they're tolerating food and hydrating well and otherwise look clinically well. That's when we would discharge.
Thank you, very nicely presented. So I love it when you challenge dogma, even if it's my own dogma, because my own dogma is to do your old protocol. But I have a plea and a question. The plea is we should just stop talking about perforated appendicitis. I mean, a hole or a fecal defines perforated appendicitis, I agree, but it's a spectrum. So especially when you're reporting from a single institution, it's really important for us to know, is it an early appendicitis? Is there an intra-abdominal abscess? Is it generalized peritonitis? Are there both? Because they're different diseases completely. So it would have been nice to know how you stratified your patients with perforated appendicitis. My question also is, you said they returned with an abscess and it wasn't different, but did your first cohort also return with an abscess, or did these abscesses develop while they're in the hospital? Because what we found is following our protocol, which is your old protocol, the number of patients who go home and come back with an abscess is typically on the 2 to 3%, and we've audited our results many times. Very, very few readmissions. When they develop an abscess, it's during the hospital stay, and it's still in the low single digits. But return to the hospital has become really, truly rare.
Thank you for those comments and those questions. So yes, this is in the old protocol and the new protocol. This is patients that met that discharge criteria on that index admission and were discharged and then returned with an abscess. We did not, we have a separate cohort of the ones that still smolder, linger, they're in hospital day 6, 7, then we have a separate protocol where they get an ultrasound, additional imaging, and diagnose an abscess there and receive treatment. So that is and for that, it's about for both old and new, was about a 7% rate.
Mike Leanwan from Kalamazoo, Michigan. My question's very similar, and I'm still not sure, and maybe I've missed it. But your 8% versus 9%, was that the total abscess rate in each group? Because I think what we want to know in this room is what is the abscess rate in each group after going home and comparing who you sent home incorrectly.
So that is the total abscess rate for those that went home in both groups.
What was your total abscess rate in both groups?
So the total, including patients that stayed inpatient and developed an abscess, was, and I don't have the exact decimal, but it was around 16% for both cohorts, and there was no statistical difference between looking at that population as well.
Thank you.
Thanks for presenting. We've been following Kansas's protocols and also some of Sharif's work as well in Montreal, and I'm Brian Kenny from Columbus, by the way. There's 2 other categories that NISQIP also considers to be complex, and I don't know if you're saving that for presentation next year or if you're treating those differently, but those are the patients who have an abscess at the time of surgery, and then the patients who have diffuse peritonitis. And I know there's actually calls within my own group that we should treat those 2 particular groups longer than we're treating some of these other things, and we're looking at our data to see if that's justified. But how are you treating those 2 groups, and why didn't you include them in this analysis of complex appendicitis patients? Thank you.
So we did not stratify based on that. It was all comers that met that definition. So some of those are included. I have not looked at that particular subgroup analysis, but that is interesting. And yes, I will try to make that presentable for next year. But yes, no, thank you for that.
Great. Any other questions? Fantastic work by the Kansas City group. And if we don't present a perforated appendicitis, it's going to boil our blood here. So anyways, nice job.
All right. Thanks, everybody.
Okay, so our final presenter, we have Dr. Sung-Hoon Kim, a clinical professor from the University of California, San Francisco, presenting Smart Silo, a gastroschisis silo that can measure abdominal compartment pressure. Dr. Kim.
So why did we do the research? We wanted to create a gastroschisis silo that measures abdominal pressure that safely reduces eviscerated bowel. This will be important because this will decrease the time needed to reduce the bowel. So how does the FDA classify medical devices? It's based on safety. So class 1 devices are things that are low risk, for example, like gloves, gowns, and things like that. The class 2 device would be moderate to high risk. This might be like needles that might hurt. Class 3 devices would be like implant devices. So the Section 510K of the Food and Drug Cosmetic Act requires device manufacturers to notify FDA of their intent to market a medical device. Most Class 1 devices are exempt from pre-market notification, 510K. Class 2 devices with predicate usually go through 510K clearance pathway, and most Class 3 devices require pre-market approval. The silo that's used currently for gastroschisis is actually classified as a Class 1 device, surprisingly. The history behind silo is that in 1967, Dr. Schuster used a Teflon sheet to sew the abdominal wall covered by mobilized skin flaps. Then in 1969, Allen and Wren used elastic material to eliminate the skin coverage so they could actually see the bowel and do an interval inspection. And then they could also do a serial reduction. And then in 1997, the company Bentec produced a prefabricated silo coupled with a spring-loaded ring. So the current design of the silo has remained unchanged for the past 28 years. So as you know, the gastroschisis is a life-threatening congenital defect that the intestine protruded the opening of the abdominal wall. And the treatment is to place the bowel back into the abdomen and to close the abdomen. And when you use the silo, it may take about a week to reduce the bowel. So here's a picture of the gastroschisis silo that's used, and you do a serial tie on the back to reduce the bowel. And then here's a picture of the typical silo bag that's used. So what are the drawbacks of the current silo? There's no means to measure the intra-abdominal pressure as the bowel is reduced into the abdomen. And the reduction is done manually, typically performed by 2 people. So there's also no means to measure the oxygen perfusion of the contained bowel. The solution is the smart silo. So the silo is designed with a diaphragm built inside. So there's a 2 compartment, the lower and upper above the diaphragm. And the diaphragm is impermeable. And there's a port site where you could inject air into the upper compartment. By injecting air into the upper compartment, this will push down the diaphragm and then push the intestine back inside. So you could set the pressure that you want in the upper compartment, which would be the equivalent pressure of the abdomen, meaning that you infer the pressure of the abdomen based on the pressure on the upper chamber. So here's a picture of the prototype that we made. And you have ground beef inside the valve there, and it's obviously we're reducing this ground beef over 2 minutes. So you wouldn't do this, you typically do it longer time. But you could see that this definitely does work. Oops, go to the next. Next slide. Sorry about that. I gotta go to the next one. To measure the oxygen perfusion, you could put a near monitor device at the bottom of the silo. And you could also do this using a pulse ox. We already published this method of measuring the oxygenation in the past. And you could actually measure the oxygen saturation of the bowel. So this is the setup. You have the near monitor, and you have air injection into the upper port. You basically tell the nurse to inject air as the pressure goes down in the upper compartment. And by doing it this way, I would suspect that the rate of reduction, I would think that it would be decreased. So the value proposition of the device is that you can measure the abdominal pressure, you have efficient reduction of the bowel, and then I think you could also increase safety. So this is the milestone for the device. So we intend to apply for NIH SBIR phase 1 grant, benchtop test device, and then register with the FDA because it's a class 1 device, and then subsequently market it.
Sangwon, thank you so much. You're always very innovative, always thinking outside the box. I'm just curious, though, the rationale, because, the silo is one of these error traps. Most of the time it works well, but when there's a disaster, it's really a problem and the whole bowel can go necrotic. But it's not typically a compartment syndrome that's causing that. Usually it's pressure on the base of the mesentery or strangulation of the bowel within the silo, and that doesn't affect the compartment pressure. So I'm just curious about the rationale for measuring the compartment pressure when you have the belly open.
Well, that's why we added the pulse ox or the near monitor sensor on the bottom. Obviously, you can't, the bowel that's inside the abdomen, you have no idea what's going on there. But I think that if you do have a sensor near the bottom, and you could get a sense that there might be something wrong going on.
Yeah, I think this is a great idea for the times when you have a silo. However, have you looked into how often you're using a silo? So there are some programs that reduce immediately and do an operative closure, and there's some programs that have gone to a sutureless closure. And what we found as we've pushed like both of that you can get the overwhelming majority closed in the immediate, first 24 hours or so, and obviate the need for a long silo reduction, which when the Bentec came out, that was very popular. And it was popular based on a few things. Number one, it eliminated for most places the need to rush a baby to the operating room in the middle of the night so that they didn't have all their bowel hanging out in a bowel bag. And so you didn't have to get out of bed for this. The fellow could pop it in, and then that was beautiful. And the second thing it made it elective. But it also fulfilled in many people's minds the idea that if I can slowly, gradually reduce, I'll decrease the risk of neck. But it really didn't influence the risk of neck. And, as Sharif brings up, it's other things. So what do you think the true need for this is? How many times do you think you'll use this a year?
Well, everything you said is consistent with what we do. So, but sometimes we do use a silo, and I think this would be a better substitute than the current model, because I think that this would actually speed up the reduction. And if you could save 1 day of NICU stay, I think that would justify the cost of the device. Yeah.
Great.
Thank you.
Don.
Okay.
All right, well, thank you everyone. This ends our session. And just a reminder to all faculty scoring presentations, please submit your scores now. As you can hear, they're getting ready for the banquet and the cocktail, which starts at 6 p.m. at the cocktail hour. Thanks, enjoy.
Thank you.